All right, so this is going to be a kind of a national registry prep. I'm going to try and be generalized so it can cover all areas, the B, the A, and the paramedic. But the focus today is definitely going to be the paramedic level. But I'll tell you now that 80% of that paramedic test is EMT basic material. There's a registry rep in the room right next door. The old man has been my mentor since 2015. He was my critical care instructor, my flight instructor. He's been a registry rep, yes, sir, for over 20 something years. That is from his own lips. 80% of the EMT paramedic is EMT material, because we learned that the best paramedics are ones that can cover the basics first. Just because a patient has SVT, I'm going to have to immediately, electrocute them with a synchronized cardioversion. I could do a vagal maneuver, possibly, if they're stable enough. So if I can be less invasive and still be as effective, I would really desire to do that because I don't want to hurt anybody. So a lot of that material is just really, can you follow a step process? The paramedic exam is not a supermedic exam. It's bare minimum competency. It's just asking, can you follow an algorithm? You maybe noticed and looked at some of the questions, like it's really just putting me on the registry sheet. It's ABCD, transport decision, then sample. It's trying to see if you know how to follow that, because how are protocols written? We could take a look right now if you want to look at the Fulton County guidelines, which I love that we've got an app for that. You look at it, hit a button, right? And you got clinical guidelines. And look, you can just pull them up in seconds and got what you need. But look how they're written. It's a flow chart. Is the patient experiencing difficulty breathing? Yes or no? If yes, do this. If no, do that. Can you follow the directions? Is what they're looking at. So today I want to spend our time wisely. Time is a very precious commodity. With the new class, it's harder for me to make time. Not that I won't, not that I can't. And you guys are always welcome to sit in at any point in time. This will be a kind of a more basic overview, but next week I'm starting cardiology for the paramedic class, and you are welcome to come and sit in there. That's probably the biggest and, most terrorizing part of paramedic school anyway, was cardiology. And where they're about to start it themselves, you're welcome to come sit in and beef yourself up if you want. Of course, you are always welcome in here. And that goes for any student of any class of mine ever, whether it's an A class, a B class. You're welcome to come to the live lectures, because believe it or not, y'all are the only students I have that have me full-time in-person lecturing. The rest of them have usually recorded videos or small snippets of when I'm doing a live Zoom, which is a kind of a rare commodity. So welcome anytime. So today we're going to talk about Pandora's box. This was a registry prep that I think I gave to the majority of all these classes here. And it was just named because it was just opening the box of just mischief, because it covers everything from airway, breathing, circulation, to cardiology, to treatment modalities, but it's a basic overview. And before you guys leave today, I have several different registry preps I want to just give you. If you don't have Pandora's box, I'd like to download it for you or do whatever I can to get it into your hands. Also, the other registry preps I bought, there's several other things that I've made through the years, like there's this one that I made that's like, it's just 68 pages of everything, the nuts and bolts of paramedicine, really. And I would like to just put that in your hands today. So that's my goal anyway. So with Pandora's box, there's some things I'm going to just highlight, and there's some other things I'm just going to deeply dive into. So let me make sure my screen's working well. Share it. Screen 2. Kabow. And we're cooking with grease. So a lot of times with students, I like to remember that, there was a couple of times in class you were probably embarrassed. It's the cost of entry. We've all made mistakes. You're going to goof up. Some of the best paramedics I know had to take the registry more than one time. Just because you pass it the first time don't mean you're going to be a great paramedic. I've had some whiz kids that had it here, didn't have it here. And I can tell you that from watching you both, all of you through the years that we've done this, through the last couple of years, that, both of you didn't have a problem in the lab scenario stuff. But again, was it test anxiety? And, you always took forever to take a test. And that's something that we got to develop a strategy for, because I want this for you. I want you to be successful, because if you're successful, it means I'm successful. It means we can continue to build this program and provide a service to the paramedics and EMTs of Atlanta, because your class is a great example, but it cost us what, $52,000 to run the program last year, and the tuition was only like $38,000. It's a service. You know, it's the cheapest paramedic school around. But look how much we tried to put into it. We paid for this. We had all these subject matter experts. And you know, their class got a way better deal than yours, because we was in a closet over at the hospital. You know, look what we got now. We're moving up every year. So, you know, it's getting better. So for me, it was 9/11 that pushed me to want to do this. You know, whatever your motivation is, find your why and really do that. If it's that 11% raise, it's a great motivator. Money motivates me. It also motivates my children. Like, that's how potty training happened. You want to go buy a toy? Yeah, we'll go sit on potty and pee, whatever it takes. So we've already talked about the cognitive exam and kind of how it's set up. It's computer adaptive. It is a shark smelling blood in the water. If you are weak in an area, it's going to hit you in that area. It is looking for 95% competency or 95% surety. You don't know what the hell you're talking about. Every fifth or sixth student, though, will get the entire test. What does that mean? The test will cut off at 70, 80 questions if you're just killing it, beating the crap out of it, or it'll cut off because you're just terrible. And some people end up at 110, 120, blah, blah, blah. But every fifth or sixth person going to get all 150, no matter what. Why is that? The registry is testing their test bank. Secondly, the first 20 questions you take are beta questions, which means they don't count against you. They don't hurt you. But what they do is they're like,
it's always the first 20?
First 20. The very first 20 questions are fake beta questions. And you know what they're doing? They're testing you. Ooh, you don't like pediatrics, do you? Ooh, airway's weak. I know how to handle you now. The test is zeroing in and scoping you for what it needs to do to test you, to verify that you have competency in the realm that is going to show whether you can do this safely and successfully, or you cannot do this safely and successfully. So some of the best resources I can give you is, to tell you the truth, on the National Registry website, it has literature that says no one source can get you ready. It even says your book cannot be the only source of information you got. Your book is good. It's got a lot of information, but I think even both of y'all, you had different books. And there were times during our school year, we found contradictory information that was more updated than your book, or it had no applicability to what we were doing or what actually made sense to our service area. So where can you go to get the actual information that is going to be on the National Registry? There's a couple places. The AmericanHeart.org. American Heart is the literature that is directly word for word, going to be on the National Registry. There were several students that got several questions that were right out of the PALS book. What is the max joule setting you can, defibrillate a pediatric at? And it was 10 joules, 10 joules per kg. 4 of your classmates had that exact question. And a lot of the PHTLS material, the AMLS material, it's word for word what is on the National Registry. So we have a couple books in the back there. If you want to borrow one, or if you've still got one, feel free to take it and peter through it, because any figure or fact you see in there will be applicable to the National Registry. Next, the National Highway Traffic Safety Administration's National EMS Education Standards. Any book that we have in here, anytime we have like a textbook, it is kind of loosely written on the EMS.gov educational standards. And the curriculum that I try and use while we're in here is based more on the education standards. Before I teach a class, I will consult the Oracle, because I have this book actually printed out and what the National Register and the US.government wants you to know about this material. So if it's anaphylaxis, I make sure I cover this term, this objective, this material, how to do that. So there's a lot of resources at your command here. So I remember med math. None of us were great at math in here, but there is a calculator on screen. But again, if you're showing good competency in pharmacology, it might be that you don't even get a drug calculation. It might be that you do. It might be that you don't. It's like we talk about blood gases. They've been on that paramedic exam for 20, 30 years now. I don't think I've ever had a blood gas question, and I retake the registry every couple of years. I have never had a blood gas question that I can remember, but some of my students have. had a blood gas question. So
yeah, I had one on this last test. It was something like you're transporting a patient. That was my biggest frustration. Not being able to remember the questions when we got back.
see, that's the thing, is that the registry wants to find that outlier. One of our students, Bigler, Marfan syndrome, we covered that in like a day. It was like a slide, maybe a slide. There's less than like 120, 150,000 people in the US that have it. And there's nothing we can do about it other than ABC, keep them alive. He had 5 questions over that. 5 whole questions over that. You can't do anything about it. And less than 150,000 people a year have it, or in the US have it. Like, come on, registry. Is that really evaluating the competency of a good, solid medic? But here's what was actually happening. The registry's got a kind of like a 1 to 10 scale. We'll use that. The registry's only looking for, 5 and 6 level questions. If you're killing those, it's going to start giving you these outliers, deeper questions. So it was giving him Marfan's questions. It was given like one of my other students got vent questions. But you know why? They're really good at the respiratory. So I was like, all right, we'll push you. We'll push you. And the sooner it can get to the higher level questions, the sooner it will shut down. But again, it's not looking for super medic. If you can hit those 5 or 6 level questions and show that you can competently work as a paramedic and not hurt anybody or an EMT, then you will be actually fine. So again, here's some links. And again, I'll provide this PowerPoint to you. Your book won't save you. And this I copied and pasted this off the registry website. Off the registry website. No single source thoroughly prepares you for the exam. You are encouraged to consult multiple references, especially in areas which you are having difficulty. At this point in the game, you should have some type of registry prep app, which looks and sounds a lot like a medic test or an EMS. So yeah, we have the exam by the numbers now. Let's look at it. A giant percent of the class in the exam is going to be, in the aspect of. So there's percentages. You're going to face at least 18 to 22% of airway respiration and ventilation. What does that mean? Depending if you're really good at it, you might only see 18% of that test being airway respiration or ventilation. Do you know which airway adjunct to use in which situation? Do you understand the difference in oxygenation and ventilation? And if you're more towards that, not as versed or great at it, you'll definitely see 22% of the test be that. Every category is 15% pediatrics. You will 15% pediatric in every category. So that means you need to go back. Don't worry about that. It's part of it. It was just, that's his project. It means you need to go back. Only do it. And to look at that PALS book and to look at that material, make sure that you are sharp on that. One of the reasons that, I feel like every time I go to an EMS conference, if there's a pediatric class, I go to it because I know that we are weaker. I am weaker. I run less peds calls. They don't get sick as often. If you ever have a chance to take the hand-heavy pediatric course, man, 1, it was a good time. 2, I learned a lot. And I'm always up for learning things, but you can kind of imagine that after being a paramedic as long as I have and going to all these conferences, that sometimes it's more along the lines of I'm being reminded of something. Unless something new and big comes out, it's just a good reminder, good course. I enjoyed the energy of the speaker kind of thing. I learned the entire 8 hours I was in there. It was worth every second. And he had me feeling like a paramedic student again. He was in there. He brought out these fake drug boxes. I was drawing meds, pushing meds. I'm running a pediatric code. It was fun. And it sharpened my skills in peds. So I was then able to take the instructor exam so I could teach that course. And the class this year is going to get a version of that. And it's going to be a good time. So there are areas where you're going to see all that. And I can tell you, everybody focuses so hard on the cardiology, the respiratory, and the medical and blah, blah, blah. They forget about little small EMS operations. You know how many people take this test and goof up just the EMS operations part? A whole bunch. Not mentioning names. Okay. But why is that? Well, majority of my students are on an engine and not a med unit. So they're on an engine, not a med unit. And you know what one of my students said from the 2020 class? And he worked on an engine full time. He said, if you work on a med unit, you have a distinct advantage on this exam. Do you know why? Because all the questions are written from the standpoint of a med unit paramedic, because that is the majority of paramedics. There's also vent questions on here, and there's also questions about certain lab values and other things on there. Why is that? Well, when we think of a paramedic, the majority of us think ambulance, Grady, kind of a thing like that. But fire medics are a thing. So are hospital medics. There's a huge percentage of paramedics that they go to paramedic school, they go work in a hospital, because in a lot of places you can sit and work in the place of a nurse. And guess what? You ain't getting rained on. You're not getting spit on by a psych patient. You're not having to deal with traffic zooming by you. There's a reason some people do that. Also, there's a chunk of medics that go to medic school and they work in interfacility transport. Hey, 911's fun and all, but I like to make way more per year. And I like to have a set schedule. I work normal hours. That's a possibility at a private service. And if you didn't know that, and you may know that, but when you become a paramedic or an EMT, you kind of got to make a decision. Do I go to a fire service where I'll have this pension and stuff, but I'll make way less per year? Or do I go to this private service where I'll make a big annual yearly, but I won't really have that much in retirement? I got to manage my own retirement. That is kind of the question you ask yourself. You may not ask it in that directive a way to yourself, but it is a direct thing. It's kind of what you choose. So tell me if this is wrong or not. In our EMTB, like, which one's the most orange? You've seen it. Let me give you a lesson on discernment. So, being from the background I'm in, you know, discernment is not choosing left from right. It's choosing right, almost right. A lot of these questions are written from the aspect of, like, there's two of them that are pretty left field. They're not even in my ballpark, but there's going to be two of them also that are so similar that it'll be very hard to differentiate between which one is the right one that gives me the right answer so I can pass this stupid test. Have you seen those questions? You have. So how do I choose the right answer? Which one benefits the patient most? Which one hurts the patient the least? Which one's more politically correct? Remember, you're not taking an Atlanta Fire or a Georgia paramedic exam. You're taking a national registry exam. I picked on Ian a lot last year because he's from Alaska. And he worked as an EMT in Alaska. I made jokes about him riding a polar bear with a light on his head to go pick up patients. But that's a joke, but there's definitely things he had to deal with that I didn't. They had to wear guns around their neck because polar bear attacks did happen. They had to, have a different way of dressing, a different way of doing things. So that happens even in Ohio. Think about Jethro up there with his big old grain silo, and he's mixing up the chemicals for this crop duster he's about to go drive in. I'm getting high as hell. What's happening? So there's a lot of aspects that it will be very hard to relate because we work in the big city here. So what is the most beneficial to my patient? What is the least harmful? If you can't do anything to benefit a patient, what can you do that won't make it worse is the answer. So I'm not going to spend a lot of time on this, but I've said it to every class. I'll say it at the beginning of a class, at the end of a class. You have to know medical terminology. I tell you this with all the love in my heart. I have taught medical terminology at a college level. And the students in the class were the ones that were going to be in my medic class, but there's also the medical assisting students, the dental hygiene students. It was just a medical terminology class for medical people, right? And I tell you now, I've retaken the registry a few times. There are words I didn't know. I had to piece them together. All right, so I know hemo means blood something. Itis means something's inflamed. All right, that's what I'm going with. So there was several words that I've had to piece together, or we get into the problem of semantics. What is semantics? Well, this word means one thing here, but means another thing here. So like if I was to say the term to you, let's go get some cat heads. What does that mean to you? Well, being from South Georgia, it's a biscuit. It's a big old fluffy biscuit that is so big it's the size of a cat's head, called cat head biscuits. You wouldn't know that up here though, right? But being from South Georgia, it's very common vernacular. So that kind of thing plays a role here as well. I say this, but it means that. Even in the fire service, you call something riding the seat, they would call it being a truckie up in like New York. Some of that translates, and registry tries to be middle ground on that, but they can't do it with everything. Because who wrote the test? Well, retired fire captain from the NYFD, probably. Or somebody from South Georgia came and was like, hey, man, you do this thing. I'm going to write a test, get me some money. Hell yeah. So we have to take into account that we may have to break words apart. And even if it's like just knowing what the N word is, like the itis, the suffix, I've had words like that. I don't know what any of those other words are, but I know something's inflamed, A, B, C, D. D is the only thing that says inflamed something. So it's got to be this one. And you know what? It worked. When I got out of that thing, I'm like, Google. Hell yeah. Look at you, boy. So I'm telling you, if you want to work on something, work on the strength of your medical term. So let's keep on moving. We already talked about medical term. So I mentioned this, but honestly, if you can remember it, to put it on a piece of paper. This is called the memory dump sheet. This is an example of one. So let me tell you that you have a piece of paper and a pen. You were given the piece of paper and pen, you remember? And a lot of people, once that test starts, you can actually write down your rule of nines, your GCS, your pediatric vital signs, and blah, blah, blah. But personally, if I can remember to put it on a piece of paper, I don't need to write it on a piece of paper. But some people, once the test starts, anxiety will kick in. And once anxiety has kicked in, it may be harder to recall that information. So if it helps you, you can create a memory dump sheet. And as soon as you get in that room, you can start writing things down. For me, if I would write anything down, it would be that I would take my time, not too much. And I would, like, if I have a scenario call, I would write out the buzzwords. What does that look like? Well, let's take a look at, I'm going to stop sharing and give you an example here. I'm going to whiteboard it for a second. All right, let me move you. So you're dispatched out to a 65-year-old male. And the writing is going to be terrible. I apologize because it's a little mouse clicker. His complaints are what? He's 65. He says, I'm having difficulty breathing. All right. He's having some DIB. Now, what can cause difficulty breathing? The more common guys will be like asthma, COPD, CHF, right? Next, he's complaining of pink frothy sputum. All right, only guy that really can cause that would be kind of the CHF or flash pulmonary edema. Next, he's got trouble sleeping at night, so paroxysmal nocturnal dyspnea. He can't lay flat and sleep. Most of the time, that's only a CHF issue. Now, look what I'm doing. I could list 4 or 5 other problems he's telling me about, but what is the number one guy that's in every category just about? CHF. So my field working diagnosis would probably be along the lines of congestive heart failure. So I get into the history. He's got a history of a MI. And most of the time, the number one cause of heart failure is because you've had an MI. So damaged left ventricular meat causes that. Does dead meat beat? No, it does not. So that damaged meat doesn't beat, so the fluid will back up into the lungs. That will usually be another what? It can be another indicator of what? CHF. So on every call that I would do on a piece of paper here, I would start writing out all right, so I got 1, 2, 3, 4, 5 or 6 things saying that this is possible CHF. The back of my glove on a scene looks like this, what I'm showing you. The stretcher sheet looked like this, what I'm showing you. We can't diagnose as paramedics, only physicians can, but if it looks like a duck, quacks like a duck, I'm going to treat it like a duck. So I'm only responsible for treating what I see or what I read. So overthinking the question and putting more there than is given is suicide. It is test-taking suicide because some of us like to overthink. Some of us like to get paralysis by analysis. I can promise you this. The way forward is what's in the way. What does that mean? The answer is in the question. We talk about buzzwords. I say shallow breathing, you say, oh, BVM. I say pale, cool, clammy, you say, ah, shock. If I say patient's a pediatric 3 years old with a high fever and he's drooling, you're thinking epiglottitis. These buzzwords push me to an area. So DIB could be asthma, COPD, or that. Pink frothy sputum, bang, CHF. Paroxysmal nocturnal dyspnea, bang, CHF. Past history of an MI, CHF. I'm getting pushed towards somewhere. So any test question you take and look at, find those buzzwords. There's going to be distractor in there as well. A distractor is like, well, Miss Smith had a hysterectomy in 1933. I don't give a crap. That is not pertinent to what's causing her problem today. There is distractor information in there. We have to learn how to navigate around it. What is pertinent? Her age? Yes. Why? Her being a female? Yes. Why? Well, she's complaining of weakness. There are 3 people that have MIs and don't even have chest pain: women, elderly, and diabetics. So her age, it means that she's had some lifespan developmental changes. She's got less water in her body. Her body processes drugs at a different rate. She's lost 50% of her nephrons, which means that she can't filter medications or fluids or anything as well as she used to. The age matters. The problems that are presented, the vitals matter. Because here's what'll happen. If I said Beck's triad is muffled heart tones, JVD, and hypotension, you'd be like, oh yeah, Beck's triad. But if I say patient's got a hurt chest from a bent steering wheel, he's got a blood pressure of 80/40, and his neck veins are distended. What I just gave you was I gave you that he's hypotensive, but I didn't give you the word hypotensive. I gave you the figure, the number. That throws some students off. He's 80/40. He is hypotensive, but you're looking for that Beck's triad to be succinct and to be pretty and to look normal and to show up in the way that you're used to it showing up. So the Beck's triad will be. So you can see how I've broken that question down. I've taken the buzzwords out, and the way is what's in the way. The impediment of action is the way through that. So what we see is that the answer is in the question. But a lot of us do what? We get into that what if scenario. Hey, well, what if this? They're not saying that. You're assuming. But the great thing, all right, 2 things. The really crappy thing about giving you a psychomotor exam like those guys are taking today, they can't smell the blood. They can't see the glass on the street. They can't really evaluate like they would in real life. That's the missing step there. But what about a written cognitive exam? They can't test me on things that I am not being asked. They can't test me on information that's not sitting in the question. So what good does it do for you to make up scenarios that don't exist? All it's saying is this: treat that. That is it. Nutshell. Go back to screen. Hell yeah. So at this point, we should have had a testing strategy. I beg you, please get a test prep out. Please get it on Medic Tests or EMT.national training or whatever one you find. But I can tell you this: if it's free, you get what you pay for. I ain't trying to get you to spend a whole lot of money, but if it's free, it's probably not as good as something you pay for. So the best ones do cost money, but the main thing you need is constant repetition. What have I said to you from the beginning of our meeting induction? Firemen learn by pain, embarrassment, and repetition. And again, I've noticed that even with my own daughter. Like, she was struggling with reading in school, and I'm like, you know what? I'm going to take some time aside. I'm like, oh God, she's got my mind, which is she's got 10 tabs open. And to refocus her, I just have to, like, we'll go through sight words. All right, this is the word. All right, she goes, this is do, are, can, cat. That one's little. Then I go through about 4 or 5 other words. I come back to little. I go about 3 more words, come back to little. 2 words, back to little. 1 word, back to little. By the time I'm done, she knows what little is, because that is the way that you guys learn, and she learns, and how I learn. By the introducing of a concept, I go a little bit further, come back to it, come back to it, come back to it, because that is how you learn. If you have what we have, which I pray that she grows out of. I won't want her anywhere near any of this fire EMS stuff. So We have what I call spatial time. How many of y'all got a Facebook or an Instagram or Snapchat or some bull crap like that? OnlyFans? Yeah, you do.
I tweet.
You sell feet pics on the internet.
I tweet.
So here's what we're gonna do. You do what you want, you're grown, but my advice is cut that thing off for at least a month because it's distracting. Think about the TikTok. It's telling you in your face, I will waste your time. Because I've been on TikTok and it's funny as hell. Matter of fact, I've gotten some life hacks. I've learned some good recipes. It hadn't, I mean, it was enjoyable. But what did it do? TikTok. We're on a time crunch. And we have to eliminate distractions. So if you've got a TikTok, OnlyFans, Snapchat, Grinder account, Bumble, Tinder, whatever, leave it alone. Give yourself a time frame. You don't need forever. You've all completed the paramedic course. You've all got the basic knowledge. It was either an anxiety thing, we timed out thing, but we have to have a strategy. We have to have preparation, and we have to give ourselves a time limit. So what does that mean for you? It means you need to set yourself up for success. That means you need to put yourself in a position where you cannot fail, which is, I don't know about you, but paramedic school was hard, challenging, and balancing life and work and all that. I was working 48s in paramedic school. I know some of you were as well. Also, I had a very, very close family friend die in my last semester. It sucked. And it was pretty. So get you a test prep app, and there's a couple rules you need to follow. Read every question twice. Why do you want to do that? Make sure that you're actually spending the time to know exactly what they're asking. It's more of a comprehension problem than a knowledge problem. Most of the time, it's more of a comprehension problem than a knowledge problem. But sometimes it does take time. It does take time. However, there are questions that'll pop up. They're just recall questions. How many bones in the body? 206, bang, done. Those recall questions save your butt. They buy your time back. And if you already know the answer to something, why spend extra time on the question? Bang, move, bang, move. You remember Marcus from your class? He wouldn't just, beat that thing down in one go. And he was like, man, that was the easiest test I've ever taken. I'm like, really? And the material is actually easier than anything I threw at you, but the stakes are way higher. Well, one, spent money this time. Two, this is the test that makes you a paramedic, so the stakes are higher. But as far as material, I can promise you what I put on you was a lot heavier than what you did there. Think about your final. The highest grade on our final was a 75. Think about y'all's final. I used to give 200 question tests to y'all. I never did anything over 120, 150 with them, I think. So I'm adapting myself to figure out what's best for the students. I haven't given this year's class anything over 100 questions. I want to build test stamina, but I don't want to also get them breaking out of their patterns just yet. So a lot of these questions are scenario based, and you got to kind of look at it with a big picture mindset, which is if you get stuck, just put the patient in front of you, close your eyes and think about what would you do if this patient was blah, 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 the blood pressure is low. Okay, well, I'm going to get the blood pressure up. So I would start a line. What A, B, C, start a line there. I did that for the critical care test. I thought I'd failed it. But a lot of the questions, I'm like, what would I do if this patient was in front of me? Scream horribly. But look for signs of criticality. What are signs of criticality? Anxiety, altered mental status, shallow breathing, pale, cool, clammy skin. Signs that the patient's deteriorating and trending down. But what are some of your options? Some of your classmates, Tyler Dean and Ginsburg, both got a similar question. It was the exact same question. It was about a patient with a CHF exacerbation that had graduated to cardiogenic shock. It was just CHF until when? Blood pressure failed. Now they're in shock. They're hypoperfusing. And it's either a pump, a pipe, or a volume problem. Well, the volume's fine. The pipes are normal size, but the pump, it's crappy. So the options were what? Fluid bolus, two things that were obviously not it, but then there was the option of fluid bolus or dopamine drip. Well, CHF, if you give fluids to, what's going to do? Drown them. A pressor, though, it's just going to squish those alpha receptors and cause blood pressure to shoot up. That's what the patient needed. So there will be times where you have to choose the most right answer. EMT mindset, you would have jumped on the fluid. Paramedic mindset, pressor. Come on, man. Move it. All right. You're going to have to watch out for airway questions. Why? Well, they're asking if you know when to use a non-rebreather versus a cannula versus a BVM. Don't read into the question. And don't overdo it. Don't overthink it. There's been cardiac patients that I've keep saying CHF patients I fixed with just by sitting them up high, put them on a cannula. Think about the SVT patient. Do I have to cardiovert everybody? Or if I can do a Denison slam and be done, not hurt them? I'd like to do that. So you don't have to assume anything. Just read the question and then use your little notepad to write out, like I showed you earlier, those specific buzzwords, those things that are pertinent to you. Read the last line of the question first. Why? A lot of times that's actually what they're asking. You know how I know it's what they're really asking? There's a question mark by it. All the following except or but. Look for those funny words that change everything. But read the last line of the question, then read the answer choices, then read the question. I know that sounds very contrary to everything we were taught growing up, right? Read the question twice, obviously, but start with the last line and then read the answer choices first. If I know it's going to be one of these four answers, while I'm reading the question, I'm already kind of formulating which one is the actual one I need. Where does it fit? Because the way to answer these questions is the question. The question gives you the answer. How do I know that? Well, let's say that 65-year-old male patient with hypotension. He's got pink frothy sputum, difficulty breathing, wet congested lung sounds. And that's all written in the question. It gave me that he's in a CHF exacerbation, right? I just have to put 1 and 2 together. That's all. And I also want you to keep it simple. What does that mean? The test is not actually trying to trick you. The test is really just trying to see, do you know what to do in a situation? Obviously, they want to make their money, but they're also in dire need of paramedics. You want to know a scary fact? Every year across the U.S., every paramedic program in existence, we only produce about 10,000 paramedics per year. Now, the scary fact is that every year, 30,000 will retire or quit the business. Hold up. That's not good. So we want you to be a paramedic, but we also don't want you to kill people. You ever played Call of Duty? There's some paramedics out there got so many kills under the belt, they got score streaks. Calling a UAV. Sad. So keep it simple. Don't overthink these things. What is there is what will be. I'm telling you, the pen is mightier than the sword. You saw what I was doing with the little cursive eraser. I pulled out the information. How do you build a house? It's one brick at a time. This is not an 80 to 150 question test. It is a one question test that you take 80 to 150 times, which means that every question, you need to suck the juice out of it. You need to sit there and really pour over it, but not too much. Don't spend forever on it. At a certain point, I'm a very fast test taker. You know why? I either know it or I don't. If I have not come up with the answer in the first 15 to 30 seconds, God be with you. See, I'm just telling you, that's just how I've always been. And I assume that some of you are just like me. Then again, you might sit there and pour over it and talk yourself out of the right answer. But let me tell you a secret. You ever had somebody stand behind you and you knew they were there, but you couldn't see them? You felt them. That's your gut. Your mind can be tricked. You can trick your mind. Your gut doesn't lie. So how many of you have changed the right answer to the wrong answer by overthinking? Every one of you have. You know why? Because you didn't trust your gut. Something inside you was telling you that that's the right answer. There's a study from Florida State University that shows that students that do that usually pick the wrong answer the second time versus the right answer the first time. So that's a hard habit to break, but I'm telling you, go with your gut. Something inside you said it was C, go with C and move it, keep it moving. I remember some of y'all's tests and like looking back over them, like you had the right answer. You scratched it out and circled something else. Why would you do that to yourself? Trust your gut. Because the only thing you really got as a paramedic on the streets is your gut. Do I got a CT machine in my back pocket? Do I got iStat point of care lab testing? I do not. I have my gut. I have a working diagnosis built off of a chief complaint, assessment modalities, and vital signs, and a history. That's all I got. So get out of your head. But your head also has to be in the right place. This is a pressure test because it's a pressure job. I got so angry last week because I have students that are not really taking this seriously. I got angry because some of them have, in the middle of a scenario, quit the scenario and walked off. How can I, in an ethical standpoint, justify creating a provider that would do that in a scenario? If I frustrated you with my little whatever, how are you going to be on a real bad scene? I've had guns pulled on me. I've been spit on. I've had hundreds of street fights with psych patients, crackheads, you name it. And so is some of you. This is not me touting myself. This is me telling you it's a pressure job. And it's a pressure test. It's meant to stretch you. But here's the good news. You have sat through countless hours of my lectures and other people's lectures. You have sat through this class. You have passed your exams. You've earned the right to sit for this test and beat it. If you pass the class, you can pass this test, because I can promise you the class was harder. When I go bench press, let's say I'm going to throw 315 around, bang it out. Then I drop it down to like 120, 135. And 3 plates on each side to 1. That 1 plate will feel real light after that 315. That's what I do to you. I push you hard all year so that when you hit that national registry, it should feel light. The thing that gets in our way sometimes is timing or anxiety. Because again, I pushed you harder than the test will. And then again, you had to suffer through the year with hours of clinicals, balancing work life, all that. I remember how it was. Pain as a teacher. So the night before, smoke a doobie. Stop studying, relax. At this point, cramming will not help you. The night before, spend time with your family, your dogs, sit there, remember why you started, have a cigar, maybe a shot of whiskey or something, and just relax. Enjoy your time with yourself. Because at this point, there will not be anything that helps. Some of you will not listen to that. You'll cram the night before. I'm just telling you what will be better for you. Anything I'm telling you is university study approved. The day of, wake up early, get a workout in. Multiple studies have proved that even a brisk walk of just a 30-minute walk before testing improves scores and reduces anxiety. What does exercise do? Releases endorphins. You will feel better. And they took and put EEGs on students' brains. The ones that have did the 30-minute walk or exercise before, their brains were lit up like Christmas trees, while the other ones had colder, more dormant spots. Why? They had exercise. Their brain had more blood flow. They scored higher, even though they weren't normally the higher scores on the tests. 30-minute walk can be beneficial. Also, being really, really well hydrated and having a good breakfast. Why would hydration play a role? Well, blood flow. The viscosity of the blood, if you've got better hydration, it will flow better. There again, a university study collaborates this. These are small little things, right? But every little nook and cranny is what I'm here to dig out today. I can tell you that if any of you have had trouble passing the National Registry, it is because of small, minute variables, whether it was timing out, anxiety, or eating crayons. Appreciate that. I know you did. So there's only two ways to get the question right. Either you know the right answer, or you know the other three aren't it. That's it. You may not know the answer to this question, but you know that this, and this, that's not it. So it's probably going to be that one. Again, rewind it back. What is going to either benefit the patient the most or hurt them the least? That is the right answer. And that is the right answer. So how we feeling? All right, so one of the things we have to do as a paramedic is establish an airway. Failure to do that means patients die. So understanding the importance of early detection of the airway problem. So being thorough in your assessment, finding the problem, and then rapidly and effectively and aggressively intervening. Patients don't suddenly die because they don't get intubated, though. That's not what it doesn't always mean airway management means intubation. It means finding that the patient has inadequate or lack of breathing or inadequate breathing and fixing it. And then doing a continual reassessment, going back and checking over what you've done, what is being done, what has been done. So adjuncts that we talk about when airway management look a lot like, this. We got the OPA. That is for patients only with a gag reflex. It moves the tongue forward as it curves over the pharynx, and it's very good for assisting in bagging. Patients do not suffer and die and get brain damage because you don't intubate. They do it because you don't ventilate. Patients have to have airflow. A nasopharyngeal airway is great for patients with a gag reflex. It moves the tongue and soft tissues forward, allows for a channel of air to flow. Nasal cannula runs 1 to 6 liters per minute. This will be more of your BB gun scenario. It's got a place, but it's also sometimes not going to be enough. You have to know when enough is enough. You got your nebulizer. That nebulizes albuterol, ipratropium bromide, or Atrovent, and epinephrine. All those are bronchodilators. You give those for what? Wheezing. So nebulizer is useful for that. There has to be a certain amount of airflow for the nebulizer to work and be effective. So that means a certain liters per minute. My sweet spot is going to be about 8 to 10 liters per minute. Any more than that, and you'll hear this sound, which means the tube is popped off of the O2 tank. Can't take a whole lot of pressure. But if you ever saw my radio strap belt, I carried a Leatherman tool that had the pincher pliers on it. You want to get on there real good and tight where it ain't coming off? Use pliers. If not, there's a chance that it will pop off. Next, we got the non-rebreather mask, or if I call it the fireman special. Seems like y'all put that on everybody. Hey, you got a broke foot? Non-rebreather. Hey, you called for needing a haircut? Non-rebreather. So it has a time and a place. It can get the oxygen concentration up to 80 to 100%. Liters per minute goes from 12 to 15. Again, you got to decide, does the patient need oxygenation or ventilation? What's the difference? Ventilation is literally moving air in and out. Oxygenation is actually just putting more O2 concentration into the patient's body so that it can participate in gas exchange and then cellular respiration. Let's get in some heavier stuff. The blades. Oh, yeah. Return of the Miller and Mack. So the Miller blade's a straight blade, size 1 to 4. It's directly going to lift the epiglottis. Epiglottis being the tiny leaf-shaped flap that covers the trachea. It's supposed to prevent you from swallowing things going down into your trachea and blocking your airway passage. But I've seen people walk down the hallway and choke on spit. Then you got the Mack blade. Mack blade is one size 4, but it's a curved blade. This guy is more safe and has less incidence for causing dental trauma. But what it does is it inserts into a pocket behind the tongue called the vallecula, and it can indirectly lift the epiglottis out of the way. Now, there's a reason for the season, and everybody's got their favorite blade they like to use. But if you are unsuccessful with your favorite blade, try a different blade, try a different size. If you went with a certain curved blade first, try a straight blade next. Try a different technique. We say the definition of insanity is what? Doing the same crap over and over, expect a different result. Have you ever seen a paramedic do that? Well, I missed it. We'll try again. They didn't change the blade. They didn't change the tube. They didn't change the head position. They didn't do anything different. Why did you expect a different result? Why? So if you're going to miss, then miss and then change things up. Next, we have the stylet. It may be inserted through the ET tube. Do not push it through Murphy's eye, which is the little hole at the end. Why? It can go through and perforate the trachea, which is a fancy word for meaning stab through it. Hey, I got the intubation, but you have a hole in your throat now. Whoopsie. And then the bougie, or as I call it, God's gift to intubation. It is just this big old long plastic tube of gum elastic, which means that it's kind of a plastic, it's non-permeable. It is usable and reusable. This is for a much harder intubation, and I've shared with you a lot of studies about if you use a bougie, it may take you a little bit longer to get the ET tube, but there's a 96% first-time pass rate, which means you'll get the tube the first time, 96% of the time. IMED did a study on it. It was very compelling. It's good stuff. I like a bougie. I really do. So we got old turd bucket here, the eye gel. Trash. But let me say that the eye gel is beneficial when it comes to speed. I have gotten patients back with it. It does have a reason for it to be used. When I tell people about optimizing airway management, of course I want to intubate. Not everybody is intubatable. And you have to have the humility to say, all right, we're going to go to an eye gel. Not just like, well, he needs an airway. Here's an eye gel. Easy button. I don't want to just easy button. You wait. Y'all never met Squishy, did you? No, this was something I did mostly this year. When I ask people questions, I just throw them a ball. It's amazing how effective it is.
You had a football.
Yeah, I had a football. That's right. Okay, I gotta find that one. So IGEL has its place in time, but don't just run to it immediately. Now, some patients, if they got a big old bullfrog neck, you probably want IGEL them. But optimal airway is going to be an ET tube. Now let's go back to the museum. You ready? Combi tube. Why do I mention it? It might be on the test, and there's still some services carrying it. I don't know why. But think about old rural Palookaville, USA. They haven't updated their protocols in 50 years. Think about the volunteer service up there in Nebraska. It's all big rural farmland. Anybody gets up out of their bed at 3 a.m. for free, you got to love your neighbor. I got to tell you, it's a whole different ballgame. Their hearts are big as barns. They're huge. But again, they got full-time jobs and family. It's hard for them to keep up their certs and to keep up with progressive evidence-based protocols. That's still no excuse not to do it. If you're going to do something, do it right. But their medical director is like 70 miles away, and he ain't looked at the protocols in 10 years. You know, they don't have any funding to buy anything but the combi tubes they've already got. You know, there's reasons here. They may not be doing the most up-to-date evidence-based protocol things, blah, 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 but half of nothing is nothing. Half of something is something. At least there is a service there that's trying to do something. So combi tube has its time and its place. It's what we call a dual lumen airway. Dual meaning two, lumen meaning that there's two holes. Hello. And one of them's going to be shooting into the esophagus, one's in the trachea. Your job is to figure out which one. You do that by ventilating one. And if you can see chest rise and fall, then you can, what's up? So the combi tube has two bulbs. There's a distal cuff and then a proximal cuff, and there's a big bulb and a little bulb. You'll feel both of them. You'll feel both of them. And again, it's really you just kind of crap shooting which one is actually going to blow air into the trachea. How do you do that? Well, you inflate the balloons and then you blow air. And you listen to breath sounds and see if the chest rises. The next guy we want to talk about, hail to the king, baby. King Airway. Oh, yeah. I actually liked the King. I'm not a big fan of supraglottic airways to begin with, but the King, he did a pretty good job, I thought. I got some patients back with it. About as many as I did with the IGEL. It works. So if you got a patient that you can't intubate, they're in cardiac arrest, they need ventilation help, The supraglottic airways are also known as BIADs, blind insertion airway devices. They are better than nothing. Some airways better than no airway. So we have to have knowledge of these type of airways, because again, you could be asked about them, and again, your service could carry them. Y'all just over the last couple of years really went to an IGEL. Y'all had Kings for a while. You know why I know? Because there's still a couple 100,000 of them in the storage room back there that are turning yellow from age. And they're like, use those in your lab. Nobody's using them anymore. You got a whole museum of crap. So here we are. So you may remember a term that I used throughout the year. If you can't intubate, you can't ventilate, you must cryogenate. In all honesty, have not criked in real life. I'm just on cadavers. Never needed to. I could always ventilate or intubate. But we must remember our landmarks, which is the cricothyroid membrane. You got the Adam's apple, which is the thyroid cartilage. You got the first tracheal ring, which is the thyroid cartilage. In between is the cricothyroid membrane. You can insert a 14 gauge needle through that, angle it down towards the lungs, and then apply the 1522 adapter, and you can ventilate through it. Now, here's the problem. You ventilate through that little needle cric. You're squeezing. And then you have to pull the BVM off, push on their chest to get the air out, because it's not flowing very well through this little straw. It's used to going through what? Mouth and nose. But for some reason, that's not an option. So you may have to actually push on their chest to get that thing to work. Also, when you cric somebody, there's going to be blood. When you surgically cric somebody, there's going to be blood. Don't let it freak you out. You are literally cutting into someone's flesh. There will be blood. It happens. ET tubes range from size 0.5 to 10. There's cuffed and uncuffed tubes. There's a reason for choosing tube size. The average adult male is a 7.5. Average female is a 7 size tube. Obviously, you can, for me, I like sometimes hold it up to the patient. But whenever I pick a tube, I always pick the tube size above and below what I think it is. So I got 3 tubes pulled out just in case. So I try to not generalize everybody, because there's, you know, there's people that'll get 1 tube size, and you got Shaq who probably get a size 10, you know. And if I gave that to, you know, someone from, you know, of smaller stature, it'd be like it got all the way to their toes. Wouldn't benefit them at all, would it? So the BVM, this is a great weapon for us. However, it can also be detrimental. If you squeeze too hard, too fast, you can pop a lung. Why? Average adult tidal volume is what? 500, 600 mLs. This thing can go up to 1600. Woof. We're going to pop the lung or damaged alveoli. We got to be very, very careful. So I'm just looking for 1 breath over a whole second of time. I'm only looking for chest rise, and that's it. I'm looking to put about 12 breaths a minute in adults and about 20 breaths a minute for infants and children. That's it. So that's probably 1 breath every 6 seconds for adults, 1 breath every 3 seconds for children. Keep it simple. All right, so about a CPAP. Tell me about the CPAP. Is CPAP ventilation? No.
No,
It is oxygenation. It does not move air in and out for you. It is continuous positive airway pressure. It is great for patients that have flail chest. Great for near drowning, because it pushes what? Pushes that fluid in the lungs back into the circulation. Also great for COPD, asthma, ARDS, pneumonia, any of that. Why? It forces gas exchange to occur. It creates a larger surface area, because think about the alveoli sitting there like a little sack. Ooh, blows it open. There's more surface area for gas exchange to take place. So we have gas exchange taking place in a bigger surface area. Any fluid down there is pushed into the pulmonary circulation, and then the patient is going to have more gas exchange occur. However, there is a negative side effect. You don't give it to ultra-mental status patients. You don't give it to patients with low blood pressure, and you do not give it to patients who are vomiting. Why?
when patient with low blood pressure, in the long going to drop the blood pressure by 10 mercury, whatever. Aspiration with vomit, and
Ultra-mental status, cardiac arrest. Yeah. So
They're not getting enough oxygen to the brain anyway,
no, they're not.
and you're forcing it, so you can make it work.
You can make things worse. So they need to be alert, oriented, have a blood pressure of over 100 systolic, because CPAP is going to lower the blood pressure. It's going to put more pressure in the chest. It's going to compress the vena cava, so less blood will be coming back to the right side of the heart, so the pressure will fall. So they need to have a certain amount of pressure in their body to get CPAP. Let's play a little scenario game. Patient has a CHF exacerbation, graduating to cardiogenic shock. They have fluid-filled lungs, right? They're wet lungs. Their pressure is 80/40, and their SATs is like 75. They need CPAP, right? Can you give them CPAP with that blood pressure?
No.
All right, paramedic, fix them.
You're gonna have to, initially, you have to start.
LASIK will take 45 minutes, probably.
Go ahead and start a fluid bolus.
I'm gonna give fluid bolus to the patient that's having drowning lungs.
Just enough to get the blood pressure.
Won't be enough. It'll drown them. What can you do, paramedic?
I mean, don't get them.
Dopamine drip. A pressor. Squish the veins and arteries. I wonder if there's a drug out there that makes the heart beat harder, faster, and raise the blood pressure without dumping fluids in there. Wait, dopamine. That was the game. There is an option. I mean, if I can get the pressure up, I can fix the problem. A lot of times we church all this up, make it sound more complicated than it is. Like, think about the patient in SVT. The heart's too fast. Well, slow it down. He's bleeding from that sliced open wound. Well, there's a pipe in there. Crimp it with a tourniquet.
But with a dopamine drip, you have to give it in fluid, right? So is it?
It's already in fluid.
Okay, so you just give it as is and.
It's usually pre-mixed bag. There is sometimes where probably some servers have dopamine where you got to mix it yourself. I've never saw it. Like, I've got examples around here, but they're fake drugs that were sent to me when I ordered from the education company. Dopamine normally comes in that big silver package. You just tear it open and start the drip. And there is some fluid there, but it's mostly being metabolized and used. Yes, it's going to hit hard and quick and fast. So I would say that problem sounded detrimental to the patient, but like, what was the real problem? I want to give CPAP, but the pressure's too low. Get it up. I think some of us think simply.
I don't think I have dopamine.
You don't, but you're taking a national registry test.
So I said, I was thinking about what we do.
Don't do anything y'all do.
Only taking
Yeah, anywhere. But do what National Registry would have you do, which means you have a full scope to play with. If there's a surgical crike on this test, you can think about it. Hell yeah. If there's you want to do a dopamine or Levophed drip, any drug, RSI, it's available to you because this is a National Registry test. So those questions will be there. Think about them. Yes, it would. And for you working here, you don't carry a pressor per se. You'd have to make one. So you have epinephrine. You could make an epi-drip. So you had options all around. But now that you got the pressure up, you can CPAP. So suctioning, you got the rigid and the soft. So rigid would be that big yonker tip, which is that Harry Potter wand looking thing. That is great for big chunks of food, vomit, blood, thick secretions. But as you suction, for the adult, you can only suction for about 15 seconds. A child, 10, a pediatric baby, infant, 5 seconds.
15, 10, 5.
That's it, 15, 10, and 5. Now, in between suctioning, you need to dip that thing into that sterile water. One, to clean it, but also so it can suck in some water to flow through the suction tubing. Why? Push all that stuff to the canister, because that thing will clog. What does blood do when it sits? Coagulates. Don't want that. So keep it moving. Even between suctioning, dip it in water, the sterile water. Also, I don't care how thirsty you are, do not drink the sterile water. It is bacteriostatic, which means it will kill all the good bacteria in your gut, and you'll have the worst diarrhea you've ever dreamed of. You think Taco Bell's bad? Try that. Hey, recruit, try this delicious water I got you. That's actually really mean. Now, soft suctioning, this is flexible French catheter. This is the suction you can either feed through the ET tube to deep suction down here, or you can feed it through a trach. Again, in between, you're doing what? Dip it in water. to clean it. So that's all I got to say about that. So respiratory patterns are important. Why? They can tell me if there's any kind of brainstem injury or activity, or for tachypnea, if they're breathing fast, there's either fever, anxiety, exercise, shock, drugs, sepsis. Something's going on. Why are you breathing so fast? Why are you like this? What has caused you to be like this? Now, what about bradypnea? There may be decompensating shock, respiratory failure. They're on opioids. They done did the heroin. Maybe a metabolic disorder, hypothermia. There's a reason they're breathing slow. What if they're apneic and they're not breathing? It could again be drugs. If you do enough heroin, you'll stop breathing. That could be in cardiac arrest, head injury, respiratory arrest. Can you have a cessation of breathing but still have a pulse? Yes. Will you have a pulse long? No. What about Cheyne-Stokes? This is usually a sign of increased ICP, intracranial pressure, a brainstem injury. It could be caused by CHF or stroke, but most of the time when you see it on registry, it'll be because of what? Head injury. An apnostic breathing is going to be from what? Brainstem injury. Now, honestly, a lot of these are going to be very hard to see in the field. Very hard to see. So what I mainly relied on when I was on the streets was they're breathing irregularly. He's got blood coming from his head. He's got a high systolic blood pressure and a low diastolic. So he's got widened pulse pressure and bradycardia. He's in Cushing's response. I can't exactly see that he's in Cheyne-Stokes because it's erratic breathing, because it's hard to see somebody's chest like doing this thing here. But you can see irregular patterns and note it as a diagnostic finding. It is still a diagnostic finding. But if you see Cheyne-Stokes or Biot's or apneustic, think about the brain being hit with something. Okay. What about Kussmaul? That's an easier one. Diabetes. Could be DKA or renal failure. The body's attempting to compensate and blow off all the extra acid it has and to regulate pH. Now, Biot's is from meningitis, head injury, major CNS disruption. Also, ataxic is the same, but they're nearing arrest. Once the ataxic means without rhythm, they're just breathing without any rhythm. They're about to go into arrest. I call that more like guppy breathing. You ever been fishing? So this is our new recruit entrance exam. Feel free to fill it out. Figure out what you want to do there. Do not eat my crayons, especially you, Celeste. I know they're your favorite. So what about the trachea that I need to remember? So the trachea is one pipe. If it gets clogged, I must unclog it. The trachea is one conduit of air. Does not participate in gas exchange. This allows air to flow through it. Now the trachea and the bronchi and the bronchioles are lined with things. Goblet cells, remember goblin cells, they create mucus to trap things, foreign bodies. It's part of the pathogenic defense system of the body. Now cilia are hair-like projections that sweep the foreign bodies out. When you cough, the goblet cells have trapped the mucus, any debris, and then the cilia help you get that stuff out. And the cough reflex is actually located at the carina. Cilia move that stuff up. So that fork of the road right there, the reflex is there. Once it reaches that, it'll tickle it and be like, hey, let's get this crap out. That's where the cough comes from. It's an irritative reflex of the lower airway. Also, beta-2 adrenergic receptors are located in the bottom of the lungs down there in the bronchioles. Now, beta-2 receptors have what? We have beta agonists, and the beta-2 receptor is going to receive that beta agonist, and it will increase cellular activity, normally in the form of an albuterol or an epinephrine, and that beta-2 activity will do what? It'll bronchodilate, allowing for more airflow to come into the system. You ever ran a fast car? Remember that big blower on top of the hood? Like you've seen the fast car with that big chrome thing on the top? That blower is to suck in more air. That can give you more power, more horsepower. So us bronchodilating the passages, allowing for more airflow, means I'm going to have a lot more oxygen flow. I'm going to have a lot more ability to create energy. Everybody with me? Hell yeah, you are. So that's repeating everything I just said. So remember, the phrenic nerve is going to originate between C3 and C5, keeps you alive. Any kind of spinal injury through that area can cause you to have a loss of diaphragmatic breathing. So that's why we must check and be careful with C-spine there. So capnographer, the gold standard of how to actually treat and manage a patient with endotracheal tube intubation and confirmation. First thing you should be doing is when you intubate is confirming that it is an actual good tube. And how do you do that? Capnography. Colorimetric's the number one way, which is if it's yellow, it's mellow, it's a good thing. Purple, nurple, titty twister, bad idea, right? Painful. So yellow is good, means you're getting CO2 coming up. Purple is bad. However, those things are only good for like 4 or 5 breaths. Then you must switch to a waveform or digital capnography. For you guys having the life packs, you can have, use that little orange little cord and hook it to your ET tube and then read capnography. Capnography is a good indicator of also the metabolic ventilation and perfusion status of the patient's body. What does that mean? Well, it means that the patient, like if you're doing CPR on a patient and you've got a capnography reading of less than 10, means your compressions aren't worth a crap because they're not perfusing the patient well enough for them to even produce it. So it's a good indicator of how good CPR is going. Managing a patient's ventilation. If you're ventilating a patient that is in respiratory arrest and they're not in cardiac arrest and you're trying to manage their capnography and their ventilations perfectly, you can use capnography to perfectly line up how well your ventilations are doing. If you got a capnography reading of like 55, which is way higher, that means they're holding on to CO2. You're not breathing for them enough. You got a capnography reading of 25, they're not breathing enough. So they're breathing too much. They're blowing too much off. So good indicator there. Let's talk about it. Why is this thing not working? Piece of doo-doo. There. So CPR, capnography waveform. So if you're doing CPR, you should have a reading of at least 10 to 15. If it starts to fall below 10, change rescuers because folks get tired. I don't know if you've ever done CPR for more than a few minutes, but it will wear you out. Good tricep workout. But honestly, you shouldn't even be using your triceps. Those arms should be locked. It should be all in the hips. All in the hips. Should be all in the hips. So those are common waveforms that we see. Now, what about obstructive airway? A shark fin is that middle guy right there. That is going to be seen in the expiratory phase, and it should be an exacerbation indicating bronchospasm, usually meaning that there's a COPD patient, asthma patient, anaphylaxis, or a foreign body. For some reason, we have issues with obstructive airway issues. If there's an obstructive airway problem, that will form a shark fin. Dun, 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 dun. They about to die. Fix it. Now, what about a ROSC? During CPR, you've got that normal 10 to 15 millimeters of mercury going on. But if you have a sudden uptake and it starts to say, hey, we got a ROSC going up to 25, 35, 40. Now it's possible you've gotten a ROSC or a return of spontaneous circulation. A return of spontaneous circulation. So ROSC, capnography is a good way to see if you've even got one. Now, everybody remember the dreaded hemoglobin dissociation curve? Left shift versus right shift. I didn't think you remembered. I remember it sucked. Well, let's just go. Recalling it is confusing. All right, let's talk about it. So a left shift will be seen in a patient that has got a high pH or alkalosis. They have a decreased temperature, so they're cold. They have decreased CO2 and decreased 2 to 3 BPG, which stands for biphosphoglyceric acid, which is a metabolic compound that you'll find from cellular respiration. Remember we talked about water, glucose, and sugar. Water, sugar, and oxygen go into the cell, makes ATP. There's a byproduct that pops out, and that's at 2 to 3 BPG. So a left shift will be caused by high pH, decrease, decrease, decrease. I've seen a registry question just like this. All the following are causes of a left shift. Decreased temperature, decreased CO2, decreased 2 to 3 BPG, or acidosis. Hold up. One of these things is not like the other. Acidosis is a right shift. That's the answer. That's the only time I ever saw a hemoglobin dissociation curve answer or question on the registry. So it's possible you could get that one because any question I got is in the test bank. You could see it. Coming soon to a test near you. So, a right shift. Causes of a right shift are low pH, causing acidosis, increased temperature, increased CO2, which means that they're hypoventilating, or increasing 2 to 3 BPG. So everything's increasing and going up, 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 except the pH. Remember, the pH is opposite. If it's more acidic, it's going down, lower than 7.35. If it's more alkalytic, it's going above 7.45. It's kind of confusing. I know. Kind of confusing. Asthma or asthma is a problem with bronchoconstriction, inflammation, and mucus production. Now, how do we as paramedics address that? At the level of the pathophysiology is exactly how we do it. If the bronchiole is constricted, I blow them up. If there's inflammation, I give a steroid. If there's mucus production, overproduction, I will thin it and move it with a mucokinetic. So what does that look like? Oxygen, bronchodilators like as albuterol, ipratropium bromide, which is also a mucokinetic. And then we got nebulized mag sulfate or a mag in a bag. Either one will work great. Mag sulfate will relax the smooth muscle and then further bronchodilate those lungs after the administration of a beta agonist. And then we have steroids like dexamethasone, decadron, methylprednisolone, or solumedrol. They will all reduce the inflammation of the airway. IV fluids, because think about how much fluid they lost. The average adult during the day, let's say just you today, you're going to lose about 1,800 cc's of fluid just by breathing normally. Think about the asthma patient. When you breathe out, there's water droplets, heat, and CO2. Asthma patient, they're going to put themselves towards dehydration zone. Give them a little fluid bolus. It won't hurt them. It'll help them. Epinephrine IM, if they deteriorate further. Epi is a very potent beta-2 agonist. It will blow the lungs up, bronchodilate, living hell out of them. And then at the very end of that, if nothing else is saving, you could try CPAP. That ain't working. Get ready to intubate. Excuse me, ma'am, what size tube do you wear? So, asthma is dangerous. It can lock them up. Now, sometimes people want to wait and call much later. They have developed the status asthmaticus, which is severe prolonged asthma attack that cannot be stopped with repeated doses of bronchodilators. This is the asthma patient you're dumping albuterol on, but it's not working. They done had too much today. It's not working. It is now desensitized to the albuterol. It's not working. Whoopsie. So you're going to have to try some bigger and badder guns. Try the mag sulfate, try the epi. May have to result to a CPAP, but it may be that you have to intubate that patient. I hope not. But if I show up and your hands are on your knees, and your tripod, and I can hear wheezing across the parking lot, and then suddenly I don't hear wheezing, it's because you're locking down. And it may be that the patient gets immediate CPAP. I'll skip all that preliminary stuff and jump to it. Or I might go ahead and start pulling out the ET tube because he's about to buy one. Either way, I've got to be ready to deal with that airway issue. Either way.
Can you go, so you said went straight to CPAP, can you go straight to epi?
If you bad enough, I will. Now we have a flow chart. If they're doing this, do that, A to B to C. No, me. If I get there and you bad, we're going to go ahead and jump to the bigger guns. Also, if you call me for respiratory distress, I'm going to hit you with all of it. All of it. Albuterol, ipratropium bromide, mag sulfate, dexamethasone, and I'm watching you. If you're improving, I'll leave it there. If not, I'll check the criteria for an epi-IM administration, 1 to 1,000, 0.3. And if you meet the criteria, like you're under 45 and you don't have any kind of like coronary artery disease, yeah, I'll hit you with it. Also, before I do that, I will monitor your vital signs. What's your blood pressure? What is your heart rate? Because if they're super tachycardic already, I'm not going to give them epi because it'll throw arrhythmias, cause them to be more tachycardic, and it could make things worse.
Normal pulse rate, high blood pressure.
How high?
179/96.
So if they had a normal pulse rate but a high blood pressure, the blood pressure could be because they can't breathe. I would probably roll the dice on them and go ahead and give them the epi and then see what happens. Because if you can't breathe oxygen in, guess what? You die. You have no airway, you have no patient. You have no breathing, you have no patient. That's why we go ABC until when? When there's not a pulse. Then it's CAB. And a lot of times for patients that are, let's say they got an asthma attack going on, right? And their heart rate's like 130, 135, or 140 or whatever. That's pretty up there. That's not doing great. I can promise you, if you fix the breathing problem, the heart rate will probably come down. I can promise you that. What you got? So the question was, if you get to the point where you have to intubate them, can you do it while they're still alert? Most people are not going to sit there and let you put a tube down their throat while they're alive or talking or alert. So no, but if you feel strong enough that I need to take this airway before they, like, let's say we pull Celette out of a burning building, he's got his throat's closing up because he's got laryngospasm and laryngeal edema coming in. We can go ahead and knock him down and out with some drugs like Versed, or if you're in another state like Tennessee, you can RSI him. We can go ahead and take his airway before it gets too bad. Because once it closes, it'd be really hard to get a tube through that. So there's a time and a place for that. In Georgia, a lot of places do chemically assisted intubation, where they just give a whole bunch of Versed or some type of sedative. They'll take the airway from the patient before they get too bad off. So yes, but also no. We used to intubate people, and you know what? It's still a possibility. I'll give you that. Not often is it done, but when we do a naso intubation, where you intubate through the nose, they have to be alert. That'd be the only time that I would see a patient doing that. The reason being was because years past, when we didn't have CPAP on trucks and somebody had a bad CHF fluid in their lungs, they're drowning in their own fluid, you'd intubate through the nose, and then you would bag them with BVM. That positive pressure would push the fluid back into the circulation, allow for gas exchange, make the alveoli surface area bigger. It was pretty much CPAP without CPAP. Now, luckily, we got CPAP now, but that would be an option if you wanted to intubate them while they're still conscious. But again, it's difficult. It's challenging. I mean, there's a lot of variables there. It'd be easier for me just to knock them down. Good question, though. You got any more? All right. Top D, or COPD. Chronic obstructive pulmonary disease. Umbrella term. It encaptures chronic bronchitis, chronic meaning all the time, bronchitis meaning the bronchioles are inflamed, there's mucus production. It also talks about emphysema. Emphysema being a fancy word meaning pretty much baggy lungs that have not the elasticity to help push all the CO2 and former air out of the lungs. So the chronic bronchitis is the blue bloater, kind of fat, overweight. They get tired by even just walking across the yard. My grandma had this. She lived next door. In the trailer next to me, could barely make it across the yard to my trailer. It wasn't far, but any kind of exertion would tax her. Also, she would be smoking the whole way across the yard, like a little freight train. I'm not kidding. I actually don't remember what she looks like without a cigarette in her mouth. That's a fact. It's a joke, but it's a fact. I'm not really sure what she looks like without a cigarette in her hand. Anytime I go back, and she's been on with the Lord now, but anytime I look back at old pictures of my grandma, I'm like, cigarette in her hand. Cigarette. Did you ever not smoke anything? So how do we manage COPD patients? Well, oxygen, bronchodilators, sometimes a dual neb is the best way to hit them. Consider steroids for the inflammation, and then CPAP. What must happen for them to get CPAP? What do you think there, Celette?
What must happen for them to get CPAP?
Yeah.
Expansion. Basically, they are very, very bad off.
How about their blood pressure's over 100? They're alert, oriented, not vomiting, and they can tolerate it. Sound good?
Sounds good.
Flash pulmonary edema. It does happen. The left ventricular failure can cause a massive pressure problems in the alveoli, and blood will backflow due to damaged left ventricular meat and dump fluid into a patient's airway or lung fields. Last time I saw this, it was she was like 70 years old. She was at a hotel in town doing some type of a conference. I get that her blood pressure is like 220 over 120, and she's complaining of chest pain, but her lung sounds are just, they're wet and nasty sounding. And what was happening was that she was having a cardiac event, and she was flashing. She was dumping fluid into her lung fields, causing flash, which means fast, acutely pulmonary edema. Now, how do I deal with fluid in the lungs? I do. So I can do a CPAP on her if her blood pressure is enough. Hers was plenty good enough to have it. I need to restore PEEP, which is I need to put more positive pressure down there, so the CPAP would do that. Also, I need to reduce afterload. So that systemic vascular resistance, I can reduce that with nitroglycerin. It can vasodilate pulmonary vessels, decreasing the pressure buildup. It also decreases the preload of the right ventricle, allowing for more flow to the lungs, and it can ease the pressure on the heart, so the heart's not having to push and work so hard. That's how you treat flash pulmonary edema. Think about a CPAP, then think about a nitro. This is how you treat it. Also a CHF exacerbation. Why are they dumping fluid? They're having flash pulmonary edema. Sometimes it ain't just a chronic thing where they're just dumping fluid all night, all day for a couple of days. It usually happens quickly.
So CHF can move to pulmonary edema.
CHF can move to pulmonary edema pretty quickly. It can flash and happen quickly. Yes.
So the days of onset is not. Can the days of onset change to that or
hours? Yeah. It ain't got to be a couple of days. It can be a couple hours. It just depends on the patient and their presentation and their circumstances of their internal environment. What variable is causing this? Is it a thing that they're having a massive coronary event? Was there some type of external stimuli that did it? There's a lot of these issues, but we're finding there's a VQ mismatch where there's a perfusion to ventilation issue that has occurred, and we have to try and correct it. So a VQ mismatch looks like, well, air's flowing in and out really good, ventilation's good, but I cannot perform gas exchange because there's fluid in the way. Another example of a VQ mismatch would be a pulmonary embolism, a PE. The airport sees a lot of these. Meemaw's been on a 12-hour flight, ain't stood up in 12 hours. She finally stands up, clot breaks off of her leg and travels. She gets it lodged in her lungs, and it reduces blood flow to that area. So they'll have a sudden onset of difficulty breathing, cough, pain, anxiety, crackles, wheezes, rhonchi. But both lung sounds will be what? Clear and equal. This is a form of obstructive shock. But what can you do about it? Support them, and then they need to go to a hospital to get that thing pulled out. Otherwise, there's not much you can do about it.